I think it's very well known even amongst the general public that stroke results in physical impairment and disability, but what's perhaps less understood by lay people is the impact on cognition, so thinking and memory, and importantly dementia. So in the early phase after stroke, many patients will have what's called delirium, which is an acute onset confusional state that's often accompanied by agitation or sleepiness, but also in addition they may develop cognitive problems that even after the delirium has resolved, they still have problems with thinking and memory. Some of the patients will already have these problems before stroke, and indeed having conditions such as dementia increases your risk of stroke. But even if you look in people who didn't have dementia before stroke, the risk of dementia is really very high. So it's about 10% of people will develop a new dementia in the first year, and that rises to over 20%, perhaps more, in people presenting with a recurrent stroke event. If you look in patients presenting with a recurrent stroke to hospital services, the rates will be even higher of dementia in the first year at around sort of 40%. So very high rates in the first year. After the first year, the risks are relatively less than they are in the first year, but they're still higher than the background population. And if you look at comparison with the background population, even after a TIA, your risk after a TIA of having dementia in that first year will be about 3 times what you might expect in the background age and sex and population match population. If you look in people presenting with a severe stroke, it's over sort of 50 times greater. So really a huge impact on the risk of dementia after stroke. And what this ends up doing is it ends up producing cognitive aging in the population with cerebrovascular events. So we can think about TIA bringing forward dementia by about 2 years, minor stroke by about 4 years, but for major stroke it can be much more, at around 15 years brought forward, or even more than that. Yes, the risk of long-term cognitive impairment, I mean, I think we can think about interventions and ways to improve the rates of cognitive impairment after stroke in terms of the sort of time course of the stroke event. So the first thing we can do is we can work better in population interventions to try and keep people's brains healthy from midlife or even earlier onwards, and that means things like improving education, keeping people physically healthy, avoiding overweight, trying to reduce the impact of diabetes, and all these things will combine to mean that the brain is more robust, so that when you do have the stroke, the impact is less. Then in terms of interventions at the time of the acute stroke, we know that interventions to reduce stroke size, such as thrombolysis and thrombectomy, result in better overall functional outcome. There's not much evidence yet, but we think that it's likely to also improve longer-term cognitive outcome. The other thing is the advent of organised stroke unit care, so providing specialist acute care on a stroke unit. We know that also improves outcomes, and that's probably partly through preventing stroke-associated complications such as infection, immobility, deep vein thrombosis, and by preventing those complications we can reduce the impact of so-called secondary insults. If we look a little bit further out after the acute stroke phase, we need to be sure that we have good secondary prevention to prevent a recurrent stroke, and we also need to make sure that blood pressure and other risk factors are well controlled, not just to prevent recurrent stroke but to keep the brain healthy. And also in the same way for midlife interventions, we should promote physical and cognitive activity. There are probably other interventions that we can think about in terms of cognitive training, for example, but at the moment there's little evidence of that. If people do go on to develop a significant cognitive impairment, we have to think about the possibility of coexistent Alzheimer's type pathology, and those patients might be candidates for Alzheimer's type treatments. So I think the first thing is that we've understood better about the epidemiology. So as I mentioned earlier, we can be more confident about the quantitating the risks. So as I said before, we know that around 10% of people will already have a dementia before the event, and then 10% overall will develop a new dementia, but that is profoundly related to event severity, and that's something that's come out really strongly in the last decade. So the severity of the stroke is tightly coupled to your risk of future dementia. I think the other things that are starting to come out are the importance of pre-stroke brain health. So the more you have an impaired brain, which may not have manifested itself as cognitive impairment, but if you have a greater burden of pre-existing Alzheimer type pathology, if you've got a lot of pre-existing small vessel disease, we know these make you more likely to have a dementia after a stroke event. So those are two key take-home messages. And then I think more recently the concept of sort of secondary insult stroke complications and the importance of things like delirium and infection are now becoming sort of hot topics for future research and might be modifiable risk factors that would result in new treatments. Yes, I think we need to do better about individualising risk prediction, because at the moment we know that on average if you have a bad stroke you'll do badly, and on average if you have a milder stroke you'll do better, and that if you have delirium you'll do worse than somebody without delirium. So we know that there are those generalities, but at the moment we're not very good at predicting on an individual patient level, and we also are not yet good about predicting trajectory. So patients who've already been declining pre-stroke, probably because of coexistent Alzheimer's disease, will probably show an ongoing cognitive decline even after the initial post-stroke recovery period. And in contrast, somebody with a robust brain will probably have a step down in cognition and then will stay plateaued. And then there are other patients who may show variations in those trajectories. So I think being able to predict risk will help patients and families in planning for the future, making key life decisions, but also it will allow us to perhaps intervene on a more individual patient basis. So if we know somebody's got coexistent Alzheimer's disease, they would be suitable for different interventions from somebody who, for example, has a lot of small vessel disease but doesn't have a lot of neurodegeneration. So I think better individualised risk prediction and better understanding of the contributors to that person's cognitive impairment will be key areas, key gaps that we need to answer going forwards.